I think I'll make a start because it's 1 o'clock. So hello and good afternoon, everybody. This is our second Matneo virtual event, so welcome. Today we'll be focusing on optimal cord management under the pre-optimisation of the preterm workstream. And we have 3 speakers today looking at the evidence and physiology around optimal cord management and the implementation of this in clinical practice. We will also hear from our Matneo clinical leads on the latest data and hearing about delayed cord clamping from an obstetrician's point of view. You will notice from the agenda that it's not a scheduled break, but if you do feel like you need a comfort break, I suggest you do not log out. And I'm sure we're all very much used to now working in a virtual world, but can ask you just to keep your microphones on mute unless asking a question. At the end of each presentation, there will be an opportunity for you to ask any questions. And you've also got the opportunity throughout the whole presentation for you to put things into the chat box. I'll now hand you over to Helen, who is our clinical lead.
Thank you, Nanette. Well, it's my pleasure to welcome you all today. We're going to spend the next couple of hours hearing about optimal cord management and from the perspective of different healthcare professionals. So firstly, Bhav Sharma will provide us with a much needed warm-up. And then I'm going to share the ODN data on optimal cord management. And then we'll hear from the kind of neonatal, midwifery and obstetric viewpoints on physiology, evidence base and practicalities. And then finally, Ursula Clark will outline the next steps to improving the uptake of OCM in the network. And as Nanette mentioned, please do share your thoughts and questions at the end of each talk. I think that will make it much more interesting. So if I can hand over now to Bhav Sharma, who's the KSS Patient Safety Improvement Programme Coordinator, to help us warm up. Over to you, Bhav.
Good morning, everybody. Well, afternoon. I'm just going to do a quick warm-up session with you. So I'm going to ask you a few questions, and if I can give you 1 minute to answer using the chat box, but don't hit the send button until the minute is up, and I will let you know when that is. So let's get started. What did you have to unlearn this year? What is a practice that you had become irrelevant? And you've got 1 minute starting now.
Well, felt more like investment.
That's the catch, isn't it?
$15 seconds. Okay, if I can ask everyone to hit send. Some great answers coming in. Ethos around working from home, it's good. Helen, that's good. Thinking I know everything. Lots around working from home.
Working from home is very popular.
Right, we'll move on to the next one. Positive gossip. You have a memory of someone who has made a difference for you. Who are they and what did they do to contribute towards your experience? We've got 1 minute starting now. 15 seconds. Okay, if I can get everyone to hit send. Great answers coming through.
I like the one from my teenage son helping me with the latest technology, because I think that's something I can really relate to. My daughter told me to have a growth mindset. What does that even mean?
Parents, it's always important to have hope.
And a senior midwife who never judges anyone. And a friend that made me laugh when things looked bleak.
I'd quite like to borrow that son. I've got a few IT problems here.
Yeah. Even for a TV remote, I need help for now.
Thank you, everyone. There's some great answers there, and I'm going to hand you back to Helen.
Okay. Thank you, Bav. Are you showing my screen there?
I will stop sharing and you'll
Okay.
be able to share.
Okay, so I hope you can all see that. So optimal cord management, we know, is simple and effective practice which improves newborn outcomes. And that includes a 28% risk reduction for mortality in preterm infants less than 32 weeks. So that makes it a really important driver in the aim to improve both peripartum care and neonatal care, and ultimately to reduce the rate of neonatal death and brain injuries by 50% by 2025. And that's just one of the aims of the Maternity and Neonatal Safety Improvement Programme being led by KSS HSN. And there are, of course, additional benefits to optimal cord management, which Professor Raber will expand on in her talk after this. But I first want to clarify what we mean by optimal cord management, and that's waiting at least 1 minute before clamping the cord. And nationally, MatNeoSIP is advocating for all infants less than 34 weeks gestational age, and that's supported by BAPM. And the focus on the very preterm infants is because of their higher mortality and therefore the possibility of seeing a greater risk reduction with the intervention. Now, MatNeoSIP has a target of 95% of eligible infants or higher achieving optimal cord management by 2025. But we know that it's not fully implemented in the UK as yet. And the NNAP data, which is the National Neonatal Audit Programme data, for Q3 of 2020, puts that figure at about 34.6% of eligible infants. So how does it look in KSS? Well, this is figures from NNAP for 2020. You'll first of all notice that it's referred to here as deferred cord clamping. And we're preferring the term optimal cord clamping or optimal cord management. It has a more positive connotation and removes the idea that an intervention is incorrectly delayed. You'll also notice that NNAP refers to less than 32 weeks, whereas MatNeoSIP and BAPM are choosing less than 34 weeks. And this discrepancy is one that Jen Lomas is picking up with NNAP. It would be nice to have them the same. However, we do know that our analyst, Jackie Bobby, is going to be able to pull the figures for less than 34 weeks so that we can see that figure as well going forward. So if you look at this chart on the left, we've got all of the units across KSS. According to the type, I'm sure you're familiar, but SCU is Special Care Unit, and that's the old level 1. LNU is Local Neonatal Unit, the old level 2, and then the NICUs, the old level 3, and then according to the LMS. And what you'll see is that for 2020, there were 491 eligible infants, of whom 26% received optimal cord management. So that's a kind of far cry from the 95% figure that MatNeo-CIP is kind of urging us to aspire to. And what does that really mean? I mean, how do we interpret these results? Bearing in mind that this was an NNAP measure that was new in 2020, so we're not completely familiar with it as we are with the other measures, such as magnesium sulfate, antenatal steroids. And that might be reflected in if you look at this percentage missing column. And so there's quite a variation in the missing data. So does that reflect the fact that that kind of translation of the timing of the cord clamping taken by maternity is not being handed over to neonatal? Are we not very good on the neonatal unit in transcribing that into Badgernet so it can be recorded? Well, that's one possibility. It's also, I think, fairly reasonable to assume that it's an intervention that's not yet embedded in practice. And that's reflected nationally and, of course, in other countries. 2021, in the first 3 months, overall, you can see that the percentage at 36% looks better. I certainly know from my unit, which is Medway, our figures have gone from 7% to 45%. And there's definitely a greater awareness as our kind of QI projects take off here. I hear it being talked about when I go to theatre. I hear the midwives calling out and timing it. So it has a much bigger presence. I think it's a little bit early to say much more about this data. You'll see for some of the level 3 units, the figures have gone down and some have gone up. And across those units where there are very small numbers, 3 months is really hard to make any kind of inferences about. So how do we support the implementation of optimal cord management? Well, it's got a key focus nationally, not just from MatNeo-CIP, but also BAPM and NNAP. And they're really important organisations to kind of drive this practice. And we know from other kind of QI projects that there are certain elements which promote success. The first is improving staff awareness, and that's what we're doing today. The ODN has done a similar webinar, and I think word gets round, and OCM is becoming a kind of terminology we're much more familiar with. There's something about addressing obstetric and neonatal concerns, and ideally, if this can be done collaboratively using the MatNeo teams from each hospital, I think that's probably something that Ursula Clark will address at the end of today's webinar. This worked really well for Precept when we had maternity and neonatal teams working together on a QI project, and we saw the increase year on year in the percentage of eligible women receiving magnesium sulfate, and that's being sustained. So if we can do the same with optimal cord management, that will be really great. We need to overcome some logistic difficulties, and I think some of our presenters later on will address that and give some solutions. A protocol always helps, and there is a guideline group in the ODN which are looking at developing one. And then finally, I think the use of QI methodology, whichever methods you use, are really great. I think the use of driver diagrams, the PDSA cycles, and using things like tools like the run charts are really visual reminders and incentives to kind of keep the impetus and momentum of any project. So I'd like to now move on and introduce our next speaker. If I'll just unshare my screen now. So we're now going to hear from Professor Heike Raber, who is a consultant neonatologist and academic at Brighton Medical School, and she's going to talk about optimal cord management to enhance physiological transition at birth.
Yes, thank you very much for the kind invitation. I hope you can see my slide. And I have to do something for my slideshow. Sorry. Can you still see my slide?
We can.
Good, excellent.
Yes, yeah.
Okay, so I'm going to talk to you about optimal cord management, and thank you for calling it like that. We invented that when we did the BAPM guideline, and I'm more and more like actually this expression because, as you already explained, it avoids the word delay or deferred or something like that. And I invite you to think a little bit about, what is happening at birth. So just to give the overview and also an explanation why the BAPM guideline chooses the 34 weeks on optimal cord management, because it's part of the whole pathway. So BAPM was tasked with doing all these toolkits, and the antenatal optimization pathway was designed for preterm babies less than 34 weeks gestation. So that's the explanation why it stops at 34 weeks. Of course, it also applies to babies who are 34, 35 and 36 weeks. Even though their comorbidity might be a bit otherwise. And it's in the pathway. So you start with placing the mother in the right place of birth if needed, and do all these things we can do for the mother. And then optimal cord clamping, it happens at birth. And after that, we continue with normothermia and also eventually breastfeeding. So if you think about what kind of changes are happening if you cut and clamp the cord, there are quite a number of them. The placental circulation, which provides the baby with nutrition and oxygen, obviously stops. And then lots of changes are happening in the circulation, like the fetal shunts have to close, the foramen ovale, and also the ductus have to close so that the circulations are separated. The lungs need more blood. So there are lots of things going on, like you have pulmonary vasodilatation, you need blood volume actually filling the lungs. And for that, the vascular resistance goes down and blood pressure has to go up. So overall, we have quite a number of changes, not only directly after birth, but also during the first hours and days after life. So if you look at what is happening to blood pressure, which we normally use as an indicator of health adaptation, it hugely changes, especially if you look at here babies born at extreme prematurity and prematurity, and also in babies who are small for dates. And when it starts at full term, even in full term babies, the blood pressure will go up during the first week of life. So that means the babies are doing it because they have to perfuse their organs. And if we can help them with that, I think that's a good thing. So there have been always a lot of debate. Immediate cord clamping was actually introduced in the 1960s as part of sort of active management of labor and a third set of labor. And now we are thinking, how can we facilitate the physiological transition during the cord clamping time? And there are various ways of doing it. Just to remind you of the different definitions, which we also put in the BAPM toolkit. So we have delayed or deferred cord clamping. That means leaving the cord intact for at least 30 to 60 seconds in preterm infants and 3 to 5 minutes in term infants. You couldn't do resuscitation with the intact cord. That means the cord is intact and the baby starts, you start resuscitation like inflation breaths or stimulation. Then as a back up methods, we have cord milking, also referred to as stripping. So that means you do gentle stripping of the cord towards the baby 4 times in preterm infants. And there are also some studies who had looked at milking the cut cord, especially in Japan, where it's now the national standard of use. However, during that, as the cord is already cut, there's no replenishing of placental blood after you have milked once, then the cord is empty. So if you think about blood distribution during the first and second trimesters, 50% of the baby's blood is in the placenta and 50% is in the baby, and there's a sort of exchange. So if you do immediate cord clamping, quite a huge amount of blood is still kept in the placenta. Nature actually helps us a little bit. In the third trimester, more blood volume is actually shifted to the baby already in preparation for birth. So that's usually about 2/3 in the baby, but still 1/3 in the placenta. So if we do the enhanced placental transfusion, the extra blood from the placenta then enables the baby to increase the blood volume very easily in the lungs. And that means you have less fluid shifts and an enhanced stability of the circulatory system. Overall, that can, compared to adults, that can be similar to a 2-liter blood transfusion in an adult. So you can see that the baby really can make very good use of their blood and really circulate blood into all the organs and organs. So why is this important, particularly with preterm babies? We know that you have a lot of this is a study from 2019 where people looked at how the blood pressure was in preterm babies who suffered severe intraventricular hemorrhage compared to those who didn't. And the blue line, as you can see, the babies who did not suffer very severe hemorrhage had much more stable blood pressures, while the others had sort of peaks and troughs. And that's here sort of even, you know, second day of life, third day of life. So these peaks and troughs, so the big changes during the course of the first days of life do put them at increased risk. So if we can avoid that by using the optimal cord management, that's a big benefit. And you always have to think about that, you know, placental transfusion is actually for free. So we don't have that very often in the NHS. So what we have seen in the randomized controlled trials on delayed cord clamping, that so here's one on preterm infants 22 to 27 weeks gestation, that if you do delayed cord clamping of at least 1 minute, the mean blood pressure is much better during the first 24 hours compared to preterm infants who had immediate cord clamping. So that's very, very good. It's very much stabilization. If we look at the study we did in Brighton, where we compared the 4 times milking of the cord, whether or 30 seconds we did at the time, the blood pressure were similar in both groups in the first 5 days of life. So that was very positive as well. So there's similar stabilization of the blood pressure. We now have some pilot studies looking at starting resuscitation and doing a mere sort of physiological cord clamping time determined by the baby. So once the baby is stable in the heart rate, this is a study from the Netherlands, pilot study in 37 preterm infants, less than 35-week gestation, not very many, very immature ones in it. So they delayed the cord clamping until the heart rate was at least above 100 per minute and the first breath was established. And that usually took the preterm babies 4 to 6 minutes. And I would like, they did provide respiratory support, but only if they think it's needed. They use a bespoke trolley, but I don't think that's always necessary. But what I really want to point out to you is here in the first minute, so 1, 2, 3, 4, 5 minutes, you can see that the baby takes their time, yeah, to get their heart rate up. So, you know, it's worthwhile waiting. So it's also the red line is the baby's less than 32 weeks. So they just take some minutes to establish their heart rate, and also the same for the saturation. As you hopefully all know, that the saturation does not need to be 100% once the baby is born. You know, it's only 45% when they're in the womb. So, you know, they establish their first breathing, you know, 4 to 6 minutes. They get their heart rate up, and of course, as the circulation improves over here, the saturation can get improving as well, because they need some time to get the oxygen into the blood and then into the different organs. And obviously, the saturation is measured basically in the skin and, you know, hand or feet. So that's really at the end of our circulatory system. So, you know, it's worthwhile waiting. You know, don't give them too much oxygen, as you probably all know. And babies will sort themselves out if we let them to sort out. So I think that that's very important results. The question is then, if you do allow for this physiological delayed cord clamping, is resuscitation actually needed? So there's a debate is open. So Nanob did a very nice study here in babies less than 32 weeks gestation, all born by cesarean section. Both groups got delayed cord clamping of 60 seconds here. Yeah. And in one group, they just did a little bit of tactile stimulation, and the other group, they opted for doing some, ventilation breaths with a little mask if needed. And what it turned out is that 90% of all babies in both groups actually breathed on their own by 1 minute of age. So the question is, so basically you only need to find out about the 10% of babies who actually need any extra help, because as I showed you in the previous picture, they can sort themselves out as long as, especially if the placenta is still attached to mom and it's still working. So mom still provides for the baby, but they're trying to adapt to all of a sudden being born. So somebody has got their microphone on. Sorry. So sorry, somebody's talking in between. Anyway, I just want to show some more slides on a study with on a publication which I have just been accepted for public for a publication, Journal Perinatology, last week. So we called it Placental Transfusion. May the force be with the baby. So that's our topic today. So I hope you all agree. And we were able to cite some historic studies, really, looking into the effect of delayed cord clamping, for example, here on the small lung arterioles. So this is immediate cord clamping. And this is the erection of the arterioles, and then therefore also better perfusion of the alveoli if you allow for delayed cord clamping. The same is, we talked about nutrition of the organs already. So this is a biopsy study of field capillaries. You couldn't do that these days anymore, of babies who had immediate cord clamping. So it's all collapsed here. And here of delayed cord clamping. So that's term babies, where you can see the capillary is nicely filled with blood. So I think that's quite a sort of key study. Same thing happens in an animal model in the liver. So these are sort of liver arterioles. And if you have delayed cord clamping, you have an enhanced vascular perfusion, and that stimulates the endocrine signals in the liver. And that means the hepatocytes can actually get activated, and thereby the nutrition provision is enhanced. So if the liver is functioning, then obviously they can digest the breast milk better. And the last example is, as I mentioned already, about the alveoli. So what happens if before the baby takes a breath, the endothelial cells are quite sort of densely attached together. And in the transition after birth, so at 2 hours, 8 hours, 24 hours, and also after 3 weeks, then they're sort of spread out, squeeze out, and thereby can much more function and also help with exchange of oxygen and CO2 on the alveoli system. So what is the latest evidence? So I've mentioned already that numerous randomized controlled trials have been ongoing. I don't want to bore you with lots of charts. After our Cochrane review in 2019, which again proved that or showed that the survival rate is improved by about 27 to 30%. We just did an updated meta-analysis together with the ILCOR group, that's the International Liaison Committee for Resuscitation. Again, that only covers studies in preterm infants less than 34 weeks, because they did another review on resuscitation of near-term and term babies, and that's why the cutoff here is different from the Cochrane review, where we did all babies below 37 weeks gestation, so up to 36 weeks. So when reading the literature, you have to keep in mind what kind of literature and studies they're looking at. So we were quite able this time to do some subgroup analysis. So we compared immediate cord clamping with delayed cord clamping. This is about mortality. So it definitely favors delayed cord clamping. If you compare immediate cord clamping with cord milking, milking is better. And if you compare delayed cord clamping with milking, there's no difference. You might be aware there was one study also published by Umbilical where they found some strange difference of higher IVH rate in babies less than 28 weeks gestation and babies having milking of the cord. So in this kind of study design, however, in the meantime, we now have 5 studies for this comparison, and there's no significant difference in mortality and also in IVH. If you compare immediate cord clamping with delayed cord clamping with intact cord, there are too few studies published at the time when we did the analysis. But overall, there's a trend to favor delayed cord clamping, obviously. And this is some more results about key comorbidities. So you need to keep in mind that preterm infants, also if they have delayed cord clamping, they still have comorbidities. So we can't avoid. Delayed cord clamping is not, solve all problems, but I think it's a good start in life, and so there are no differences if you compare milking with delayed cord clamping about the severe IVH, chronic lung disease. They still get chronic lung disease, neck. However, there was a trend that neck incidence is lower in babies who get delayed cord clamping. Bilirubin and peak hemoglobin and peak hematocrit are the same in 24 hours. So this is a summary of all the studies, all the meta-analysis which have been done recently. There's another very nice network meta-analysis by Jazani, also published in early this year. So the main message we have already talked about a couple of times, that there's a reduction in hospital deaths by 27 to 30% if the babies get their placental transfusion or optimal cord management. The few studies could look into higher circulatory blood volume. We have mentioned the better blood pressure in line with that. They need less inotropes. They need fewer blood transfusions. And there's some cardiovascular effects. Overall, there's a trend to reducing necrotizing enterocolitis, better oxygenation in the brain, lower frequency of any intracranial hemorrhage, but not necessarily the severe ones. And so far, we have not found any adverse effects on neurodevelopmental outcome at 2 years of age. In anything, the boys do actually a bit better. So why do we clamp the cord immediately? There was a thought in the 1960s that immediate cord clamping might reduce the risk of bleeding after birth. However, recently there have been studies which shown that this is actually not the case. So now the WHO has published a recommendation in 2016, which actually say, which is quite exceptional for WHO, that immediate cord clamping is contraindicated. Yeah, so that's a very clear message which comes out from the WHO guideline on that. Other risks I've mentioned already. People are worried about jaundice, polycythemia, resuscitation, and poor temperature control. However, we can do quite a lot about that. We can provide them with a warm room. We use the plastic bags and the very immature ones. You can put the baby a hat on. I think that's quite often in the guidelines, and use warm towels if you have. With regard to temperature control, there is a very nice study recently in 2020 looking at near-term lambs who either had immediate cord clamping or delayed cord clamping. And those who had delayed cord clamping actually maintained their temperature better in the first 10 minutes of life. And we see this trend also in the meta-analysis we do in the human studies. And I think it's because the circulation are better for the preterm infants. They are able to maintain their temperature better. But we still have to use all the other measures like I've mentioned in the slide before. With regard to jaundice, there's no major differences in duration of phototherapy or indication, and no studies have actually reported that polycythemia was any sort of clinical problem. In the preterm infants, we do take quite a lot of blood out of them anyway, so most of the extra blood lands in the laboratory, unfortunately. So we still have to work on that as well. So in summary, so the mortality is improved by 27 to 30% if you do the optimal cord clamping. Survivors will develop comorbidities of maturity. So far, we could not identify any increased risk for the baby, and also no increased risk of postpartum hemorrhage in the mother. Certainly, immediate cord clamping may cause harm by reducing chances for survival. So, as next steps were already mentioned by the speakers, we would like to recommend to make plans for implementation. We need to use an MDT approach. All people who are involved in the care of mother and baby have to work together, and we should audit our own practices.
All those measures that you are taking to try and secure the vaccines.
Oh, somebody's talking about vaccines. Interesting. So just 1 minute slide about the term infants. For term infants, we should really wait for 3 to 5 minutes before we clamp the cord. So it's no need to rush, or you can actually wait longer, but don't lift the baby up above the level of the placenta, because sometimes you can have, if the cord doesn't collapse, you can then have a baby to placental transfusion the other way around. Benefits have been they're slightly different than in preterm infants, but there's a nice study actually from Uruguay, where somebody, Jose Diaz Rosselli, put babies on a scale which was continuously measuring, and what they found out, that the body weight actually obviously increases as the placental transfusion progresses. So that's definitely the thing. They do better with the temperature, with their cardiovascular system and hematological values and renal function. But what is really, really important for the term infants is, because we do not take so much blood out of them, that have a better iron storage for 6 to 12 months. So you wait 3 to 5 minutes, and they have better iron storage at 6 to 12 months. And that's extremely important for every baby, but particularly for babies in developing countries, because in the first year of life, there's a lot of mortality from infections. And if you have better iron store, then you have less infections. And the other marvelous thing is really, which really excites me each time I talk about it, that you wait 3 to 5 minutes, you make an effort, and at 4 years of age, the child has a better neurodevelopmental outcome and development when they go to school. Yeah, so you make an effort 3 to 5 minutes, they are better at 4 years of age. So please, think about them as well. So I find this quite remarkable. Anyhow, so back to our BAPN toolkit. How do we proceed from here? So we remember 1 minute. We would like to really concentrate on this 1 minute. So we do not recommend early cord clamping at all, if at all possible. And we would recommend to develop unit guidelines according what is locally possible. You have to look at your own labor ward settings. There are a couple of examples and guidance on how to proceed also in the BAPN toolkit, because the Southwestern network has done very nice work on that, the Preterm network. We do not recommend any special equipment, because it can be done without any equipment. We recommend an MDT approach, and parents should also be involved. I'm always impressed by our parents here in Brighton, that when I see them in antenatal clinics, they actually require, can my baby have delayed cord clamping, so that they are told about it in the antenatal classes. So I'm very pleased about that. So on that note, I know we are very, very bad in actually recording our own delayed cord clamping time or milking of the cord. The improved numbers for the Royal Sussex County Hospital is because every week I recommend to the colleagues that they please record it not only in our electronic patient record, but also on the BadgerNet system, so it does not get transferred. So the reminder is what is key. So I would so from our viewpoint, I would recommend that the BAPN toolkit can be used as a KSS improvement project. The network guidelines currently drafted. I'm on the writing group, and we meet again next Monday. Everybody could look at whether their unit guidelines need to be needed. But what I'm also really after is that we should now, I think everybody has this maternal BadgerNet now for all the births, that we document optimal cord clamping management for all deliveries, also for the term babies. I think that would really, really help everybody. And the question is, I don't know, do you need local champions? And I think we have already started looking at auditing the practice, so encourage everybody. So I thank you very much for your attention, and I'm happy to take any questions.
Thank you very much, Heike. Before we move on to the Q&A, in the chat box, I think we've actually put out for the Survey Monkey. So if you can complete that as you're going along with the presentations, that will be great. And I must say, I found your presentation absolutely fascinating. I was just trying to draw out on particular what slides I like, and I really enjoyed May the Force Be With You, those 2 slides.
Yes, that's a very hard, the paper very hard to our, dear to our heart, from Judy and Deb, my friends in America, and myself. So yeah, we are proud that they accepted the title. So
it's
I hope
absolutely brilliant. Absolutely brilliant. And I love the summary as well about the benefits of optimal cord management for the term babies. It's a really good reminder, I think, for staff. I think Helen's got her hand up. Have you got a question, Helen? Is that?
I have. Thanks. Hi, Gary. I really loved that presentation. And it is. I agree with Nanette. It's really great to have the highlights for the term infants. We shouldn't forget them in this process. Seeing all of the evidence that you present, you know, not just your own kind of basic science research, but also the reviews, and looking at some of how old some of these reviews are. I wonder what your thoughts are about why, yet again, it's taken us so long to get evidence into practice.
Well, that's quite typical in medicine, especially in neonatology. And one thing is, overcoming the sort of psychological barriers and doing something new. On average, we account for about 10 years if you do changes in neonatology. I mean, recently it has gone a bit better, and maybe we have also learned from the COVID pandemic to put things into practice as soon as they became available. We had international webinars to learn from Italy and Spain as they had the first babies, you know, sort of thing. I don't know, maybe it's because also the interface between the obstetrician or midwives and the neonatologist or pediatrician has to be really, really tight. So one thing what they found useful in the Southwestern network is that one of the neonatal team, a registrar, for example, scrubs up if there's a cesarean section. So that the obstetrician tells us that gave them some reassurance, because for the obstetrician, if you think about it, they're doing all these active things with the mother, you know, they're doing a surgery, delivering the baby, thinking about this, that, and the other, and you know, bleeding and whatever. And then all of a sudden they have to stop and wait. So that's like a, you know, a sharp brake if you brake with your car in front of an obstacle. I think that's probably a psychological thing. And then the other thing what is still missing is that we don't really pick up the heart rate reliable of the baby once you're waiting. So I'm working with the Sussex University engineers to get some device which we could, non-invasive one, which could just pop the baby on and give you a heart rate. But that's future music in science. But I will persevere, I promise. So in the meantime, I think one of the things I was thinking, this tip from the Southwestern network, whether we should make it compulsory that if we have, you know, if we get the time, if one of us scrubs up, and then still have the consultant in the background telling everybody keep calm, make sure the baby is held straight so you don't kink the trachea, don't kink the airway, so they actually have a chance to start breathing and get adjust that they're not all of a sudden not more in the uterus, and it's quite a different environment, so it's a bit of a stress for them. And also remind they can still recover from the bradycardia. You know, if you think about your CTG recordings, you know, they have the bradycardias when you get a contraction, and then they recover. And that's what's, in a way, taking the baby out, maybe it's like a contraction to them. So that is like a vagus stimulation, and that also happens. So, for example, in the ILCO resuscitation, they're getting away from the sustained inflation breath at birth, because that putting just a mask on a baby's mouth and nose, that will cause a vagotonus in them and actually makes them bradycardic. So you're achieving the opposite of what you want to actually achieve. So these sort of fine details might help us with overcoming the barriers and working together, and then reviewing, you know, how we can achieve it.
Yeah.
We've got one question as well from Claire Redfearn, who says, does milking the cord have any risks for an extreme preterm baby with vascular changes with forced volume transfusion?
Yeah, so that's a big discussion amongst the people also doing research on that. As soon as Anup Kateria told me about his results before they're even published, and we did an audit on our preterm infants because almost all of them get milking of the cord, the little ones, especially if they have cesarean sections, and we did not find an increase in intraventricular hemorrhage. So that was a 3-year audit in Brighton where we're using it for 10 years. So I think that probably has to do with the technique, how you're doing it. When you look at when you talk to people who are in the multi-center trials, some of them actually had 0. So I know for sure about a university hospital in Germany who are participating, and they are very experienced in optimal cord clamping time, and they had 0 IVH in both groups. So there might have been some university or some hospitals who might also have a higher incidence of chorioamnionitis. So, and as I mentioned in my talk, the optimal cord clamping time management does not prevent all comorbidities. Some of the IVHs also start intrauterine. If you really look early with the ultrasound, we see quite a number, especially those with chorioamnionitis. Whatever you're doing, they will be off sick. You know, they have coagulation problems and so forth. So the important thing for the milking is not to do it like they did in the lamb study in Australia. So what they do in the lamb studies in Australia is they had the lamb has got a very short cord. It's only like 20 centimeters maximum, very thick. So the volume in the cord, in the diameter of the arteries is very big. And what they did, they clamped the cord on the lamb side, let it really fill, and then clamped it on the other side, the placenta side, pulled it off, stripped it off, and then closed and opened it alternatively. And this is what we are not doing in milking of the cord. Our obstetrician only holds the cord very, very gently and then sort of milk across. So I think as the baby, and often the baby starts to breathe then. So what you see is they start breathing because, blood is coming. And then I think they will direct the blood into the lungs. But that's my personal opinion, and other people might have other opinions. So we have to recognize.
We've just got one more question. Sarah Ward said, great presentation, thank you. What would you suggest for delayed cord clamping or umbilical cord milking at a cesarean section?
Well, I mean, is that for preterm infants or? So for preterm infants, our obstetricians like the milking more because it guarantees the transfer of the blood. But now with the new BAPM guideline come up, they really make an effort. So I'm really appreciative of that. So what they now do, they start with delayed cord clamping, and if they think they can't achieve the 1 minute, they milk at the end. But you have to be careful. Looks at the baby become red. So if the baby becomes red, you know the transfusion is happening.
Thank you. Is there any more questions anybody would like to ask? Raise your hand or pop it in the chat box. No, thank you so much. That was really interesting. Really appreciate your time. Thank you. Back over to you again, Helen.
Yeah, thanks very much, Heike. So next we're going to hear from Dr. Vanilla Ponissami, who's a consultant neonatologist at Ashford and St. Peter's, and she's going to take us through a practical guide to the successful introduction of optimal cord clamping.
Thank you, Helen. I'm just going to share my screen. You able to see my screen?
Yes, we can.
Lovely, thank you. Thank you very much for inviting me to talk today. I think following on from Heike's talk, I'm going to just focus on the practical aspects of how we introduced optimal cord clamping in St. Peter's Hospital. So I'm hoping this will give you a little bit of an idea of the practical aspects that you can take and adapt it to your own units. We started this in 2019, and apologies for the terminology, because while I like the optimal cord clamping, we started off before the BAPM guidance came out, and we called it as delayed cord clamping. So the guideline in our unit has got it as DCC rather than OCC or OCM. We used to do umbilical cord milking for nearly 10 years before we thought in 2019 that we should try and do the physiological deferred cord clamping. And that's because of the meta-analysis coming out saying at least 30 seconds of deferred cord clamping was beneficial in reducing mortality in under 32 weeks gestation. So in the beginning, we started off to say, let's try and achieve at least 30 seconds. And then as we got more confident and the BAPM guidance came out, we then changed the minimum time period to 60 seconds. We also tried and do it rather than just at an upper limit of 1 minute, to try and do it for until the baby is breathing. And we set a target maximum of 3 minutes, but allow the baby to have a patent airway, get the breathing established, and then clamp the cord. We call this as a new ABC approach. When we started this in 2019, we wanted to do it both for cesarean sections and for the vaginal deliveries. So we needed to try and find ways where we can keep preterm babies warm. So we, at the time, had these new bags in the market, which were the only sterile bags that were available. So we tried a trial period with the NeoHelp bags, which has got the Velcros in the middle, so it's easy to get the cord come out, and also has a little covering for the head, so to keep the babies warm. We also wanted to try and have a platform, only because in cesarean sections it was more comfortable and feasible to do it. So we tried a trial period with the Life Start, and I spoke to Liverpool, who were pioneers in designing this and implementing this in their hospital for many years, which was really useful, so we can kind of know the pitfalls around it and only use it to the extent that is actually feasible to use in real practice. We did some modifications to it to suit our unit and had a NeoPuff installed on it, which was more familiar for us. And then what really was helpful was doing a number of simulations. It helped us to design how we can actually implement this change in practice within our units. We tried it for both labor ward and for theatre. And we worked out where it's feasible to keep our equipments and the team members to stay, and what sort of minimum number of people we needed to attend a preterm delivery. In the process of this, using simulation, we also kind of became more aware of the number of equipments and people that would be present in a delivery and how complicated it can be in terms of their roles and responsibilities. So for a baby under 28 weeks gestation, we generally have a couple of doctors, a registrar and an SHO, and a couple of nurses, a junior nurse and a senior nurse, who go down with the resuscitation trolley to help. I guess that's kind of fairly common in most level 3 units. And we then have an additional slight difference because we use a mobile Vaportherm to stabilize babies under 32 weeks gestation. So we avoid them being intubated. So we had an extra equipment there. So bringing the Life Start will be another equipment on this setup. So we then came up with a role for each doctor, so Doctor 1, Doctor 2, Nurse 1 and Nurse 2, and designated each one to be responsible for one equipment. So they know that they are responsible for making sure they take that equipment, check that it's working, and also know their role at delivery. So something for before delivery and for at delivery. So Doctor 1, who is a doctor who actually gets scrubbed in the theatre, like Heike was saying. So they are actually replacing the midwife in the theatre for providing the optimal cord clamping. They would still be responsible for Resuscitation, which is the basic equipment. And the Doctor 2, the additional doctor, will then try and facilitate the optimal cord clamping by getting the equipment around it. And Nurse 1 was helpful in making sure the baby's ventilation is managed with the mobile Vaportherm. And Nurse 2 was there for additional help with the resus trolley and surfactant if needed. We also wanted to enforce that it's actually not just a neonatal team that's needed. We need the support from the midwifery team, the obstetrician, and from the theatre team. So changing this from umbilical cord milking to the deferred cord clamping meant that we needed to tell the midwives what we expected of them to do. So in the beginning, we had a big discussion about where to keep our equipments. We decided if we're going to use a special platform, it should be easily accessible. So it was kept in the labor ward, right where it's needed. And then we started off with the midwives doing most of the checks on the equipment in the mornings as a routine, along with their usual checks of the resuscitation and labor ward. But later on realized actually it's too much of work for them, and then we changed the process so it's shared. So they make sure it's clean and ready, and the neonatal team will make sure it's checked every day at the start of the shift. And then also we kind of advised what they could do to help us keep the baby warm inside the bag and make sure the cord's not like kinked or like felt or blocked, and be ready to clamp the cord when we tell them to do so. Theatre nurse is really, really important in terms of enforcing this or facilitating this in the setup of cesarean sections. I think we had to make a few modifications to our setup. I'll show you in a video, and also get them to make sure the sterility of the field is maintained, because while one person scrubbed from the neonatal team, some aren't, and inadvertently there is an enthusiasm to come closer to see the baby. So it's really important to make sure that we don't compromise the sterility in theatre settings. We wrote up a simple standard operating procedure, essentially keeping to our standard practice but introducing the optimal cord clamping. So we wanted to make sure that we continue our usual way of stabilizing them on mobile Redfearn, but leave the cord intact while we do that and assess the baby, make sure the baby's had their first breaths before we clamp the cord, and aim for a minimum duration initially of 30 seconds and then later on to try and do it for at least 1 minute. We also around the same time introduced a birthday cuddle, so it was a nice opportunity to update the guideline incorporating both of these, and also making sure that people know in what order to do and how to move around the room, which is quite small in some of our labor ward. The other important thing is to making sure that obstetricians know that they don't deliver the baby with the sac intact, and place them on our trolley or on the neo-help bag, because that will make the baby very wet when we open up the sac. So it's really important to make sure that doesn't happen. And coming back to the points that people have been raising in the chat, and Heike was also referring to it about capturing the data. I think that's really, really important, because often they do it, but we don't know unless we were there at the delivery. So we had to update our stabilization chart. I think it's gone probably 15 versions in the last year. And we had to try and make sure it's simple tick boxes that people can do. And at the end of it, if it hasn't gone into the database or into the Badgernet, we were able to go back on a monthly basis. So we have a delayed cord clamping team made up of our neonatal nurses, doctors, and myself, who will go and check these data on a monthly basis and make sure it's actually entered in Badgernet correctly. All these changes we implemented deferred cord clamping in August 2019. That's in the very first baby that we did it in our theatre, and you can see there's quite a lot of people. So we have our resuscitator in the corner. Resus trolley is just hidden behind there next to the doors. There's a mobile Redfearn right by the nurse one, and the life start platform there. If you see the setup for the theatre nurse, normally they use a Mayo table which comes right across and blocks the view, so somewhere there. It's easier now to have it as a side table so it doesn't block the view of the rest of the team who can actually see the baby. In the beginning, wanted to make sure that it's feasible for both staff and parents. So we collected feedback for both delayed cord clamping and for the birthday cuddle. And it was reassuring to know that generally people felt comfortable, because lots of concern was from the team to say how would parents react and will they be okay waiting. But actually parents are very, very happy to do it. And when they know the reason why we're doing it, they don't seem as an undue delay in getting to the baby. So there's no rush to clamp the cord and get the baby to the parents. And the staff feedback was really helpful to try and modify the setup, how we do things in a way that actually all the team members are comfortable in their own roles and responsibilities. We looked at the data for the first 9 months. We presented this last year, and we wanted to just make sure that by introducing something different when we were actually doing an umbilical cord milking, we didn't want to make things worse in any way. So it was reassuring to know that we were managing to do on an average of about 70% of deferred cord clamping, and that was for both preterm babies and for babies from 32 to 37 weeks as well. And we managed to do it in our usual way, with the majority of the stabilization being done on Redfearn. We had good uptake of birthday cuddle, good maintenance of temperature and blood glucose in the first gas. So this is our run chart from the time we started till last month. You can see it's up and down, and majority of the time in 2020 we were about 70-75%, as it was reflected in the first chart by Helen on the NNAP data. This is slightly different to NNAP data, because NNAP looks at babies per quarter when they are discharged. And this is per admission, because it was easy for us to do our audit per month on admission to give feedback, which was more realistic for people to know, because babies born in December get home in the next quarter. So you can see the rates for St. Peter's fell in the last quarter, which is the 2021 Jan to March. And that's because here we didn't do so well last quarter of 2020. So those babies are being discharged in this quarter or the last quarter, and therefore you can see the rate fall down. This is, I'll come to kind of the reasons why this happened in November to January in 2020, but it's not very, it hasn't been very easy to increase the uptake consistently to get to where we needed to. Thankfully, in the last 3 months, we've been much better. And I think that's partly because of the drive that BAPM has given more to the obstetricians and to everyone to actually see how important it is to do it. So that's just to give an idea of the gestations that we have generally dealt with. So the smallest baby we did was 22 plus 4 weeks gestation twins. We actually didn't use a LifeStart platform for this babies. They were vaginal deliveries. Twins, the room was very small, so we decided prior to the birth that we will actually just do between mum's legs and have a setup ready if we needed to support their breathing. And it was really feasible to do them for a minute. And we also had the smallest baby of 465 grams who was effectively managed with optimal cord clamping. So when we looked at the reasons over the last 18 months as why we haven't been able to really improve our rates of DCC, some of them were because of the equipment. I think in the beginning, when we start something new and a fancy equipment comes, people are quite excited, and they used to forget that it's the aim is to do deferred cord clamping. The aim is not to have to use LifeStart. So we had to try and work a lot using simulations to get away from being worried about LifeStart. Often it was not used when it was not checked, not ready. They thought they couldn't switch on the gases. But as we have gone through in the last 18 months, we've realized, like Professor Abe was saying, we actually haven't been really using any support in the LifeStart that much. We can see the babies start breathing by themselves if you just have kind of patience to wait and allow them to have the deferred cord clamping. Few other issues were related to babies delivered with the placenta. So when there's an abruption and the placenta comes often with the baby intact, particularly in very preterm babies under 25 weeks gestation. In the beginning, there was less data in 2019 about doing deferred cord clamping for monochorionic twins, particularly if there was evidence of twin-to-twin transfusions. Subsequently, there's been more work on it, and the publications have been reassuring to see that you can do them for twins similar to singleton babies. Also, the issue of short cord was a problem, and that's because people were more worried about the short cord, and it wasn't really the true short cord. Often people will not get close to mother, either in the vaginal delivery or in the theatre, and would then end up thinking the cord is too short and can't get close to the baby. So we've now tried to reassure people that it's actually feasible to, and if it's not possible to, then get the equipment out of the way, and the scrub doctor could actually get closer to mum's abdomen or thighs and do the deferred cord clamping using the sterile bag on mother's legs. And again, thanks to BAPM, I think the BAPM's guidance on the special circumstance management has clearly covered these 3 points. And I think that has been a huge help in getting the buy-in from the obstetricians, from the midwives, to really feel confident that we can do deferred cord clamping in almost all the babies. The other set of problems we had is the confidence in the team. And that's both the neonatologists and the obstetricians, where they end up panicking and thinking the baby's not breathing, oh, the heart rate's less than 60, or the baby looks pale, so let's clamp and cut the cord. But actually, the more we've been, the senior people have been around and present and tell the juniors to calm down and listen, I've had feedback from some of our registrars who come and say to me, actually, after a minute, I can see by the time the baby's getting pink, a baby's heart rate picked up and we didn't do anything. And then I was happy to wait for longer than a minute. So I think we just need to hold our nerves and let the baby start breathing. And they do that if the placenta is intact and the blood supply is getting to the baby. There are very few circumstances where when mother's been unwell and has been under GA, people have been wanting to care for mom and therefore have clamped and cut the cord. And sometimes I think that may be unavoidable circumstances. Since we've started this, we've had a number of changes along the way, listening to the feedback and making sure that we improve the rate. So one of the things we've done in the last 6 months was making sure the equipment doesn't interfere with this. So we produced a kit which has all the accessories that we need, so it doesn't kind of interfere when people trying to set it up when they really need to use the lifestyle. Most of the time, they don't use any of these. It's just the confidence of knowing that it's there allows them to be prepared to do it. And having a checklist, which is easier to tick at the start of the shift, mainly to making sure the cylinders are there with the enough oxygen and air that if they needed to do neopuff, it's available. We've done loads of training. We have now incorporated a session for DCC for 1 hour in our induction every 6 months for doctors. So we introduce them to the concept, show them the equipment, play a couple of videos, and make sure that they are empowered that if they attend a delivery as a senior doctor, that they should be expected to do deferred cord clamping and document if they can't do, and should be able to justify to the DCC team why they haven't been able to do. And in a way, I think that's given them the confidence that they can be the spokesperson in the team. When they come in new and they don't know the setup, that they have been given a voice to talk about deferred cord clamping. I would like to show you just a second video. Apologies if some of you guys have seen it in another talk. It's available freely to see on YouTube. I'll just play that. It kind of plays for about 9 minutes.
When you decide to use the Life Start for delivery, it's important to discuss with the obstetric team and the midwifery team to ensure that everyone is happy to use it and that there are no contraindications. It's also important to let the parents know what you will be doing. The other thing to check is the height of the maternal bed to ensure the Life Start will fit around this.
Remember to wear white aprons if you're in labor ward to protect yourself from amniotic fluid or blood splashes.
Bring the knee and help bag. Right level.
Please do not touch the cord at any time. There is no need to check for arterial pulsations, as delayed cord clamping is all about venous return from the placenta to the baby. Please ensure the cord is straight with no kinks. Most importantly, active management of thermoregulation in labor ward and theatre is important when providing DCC. Appropriate measures should be taken to improve temperature and documented. Please remember that it's good for babies to have physiological transition of breathing established before cord clamping, the new ABC approach, airway, breathing, and then cord clamping. We aim to do at least 30 seconds of DCC and a maximum of 3 minutes if the baby remains well. If unable to do even 30 seconds of delayed cord clamping, then do gentle cord milking.
Give him a bit of sugar into his mouth. Keep his blood sugar up. Lovely. Okay, stick that in there.
Right, so what we'll do is we're going to wrap baby up in this towel to keep him nice and warm. Give him some sugar. We'll have a cuddle your baby. Bring the fax machine. Okay. There we go. Congratulations. Yeah, who's come? You got him? I'm going to touch him. Yeah. Can you give him a kiss?
We aim to facilitate a first cuddle for the babies with their mum or dad, and we call this a birthday cuddle. This is done soon after stabilization before transfer to neonatal unit. It's hugely beneficial to both parents and babies. We aim to transfer babies to NICU by 20 minutes of age and plan the duration of the cuddle accordingly. In terms of parental views on delayed cord clamping in preterm babies, it allows them to have an as similar experience to term babies as possible, as parents will be able to witness the stabilization at birth. Very limited research has shown that parents witnessing resuscitation in a supported way is more beneficial than otherwise.
Starting at the top, everyone introduce themselves. Marie Ann Eustace.
Mahmoud Separation.
David, neonatal registrar.
Joe, the neonatal nurse.
Liliana, neonatal nurse.
Mary, midwife.
Emily, neonatal SHO.
Susan. Okay, and here we have April Williams. She's pregnant to para 1. She's 25 weeks plus 2 gestation. She's got intact membranes. She's had her steroids. She has hospital number 127533. And the additional information is we're going to be doing delayed cord clamping and using the line style.
Heartbeat is less than, if I can begin, please.
I'm giving 5 high breathing breaths. 1, 2.
It is important to document if live start was used and the method of cord clamping, i.e. delayed cord clamping or cord milking, the duration of delayed cord clamping, and any reasons for not able to provide DCC in the admission notes.
Right, it's 2 minutes 45. Please prepare to cut the cord. Temperature 37. Right, 3 minutes. Please cut.
that gave you an idea of how it was done. As you can see, I think because we did this video right in the beginning, people were very enthusiastic to wanting to give IPPV when the baby was already having some breaths and breathing when the heart rate was low. So that's the thing that we had to change in practice with more experience and letting people to kind of believe and calm down and not panic. Doing regular reviews every month based on the admissions was really helpful to feedback to the team that were involved in every preterm delivery. And as I alluded to before, I think having this BAPM preterm optimization care plan has helped us to work much more jointly with our obstetric colleagues. Since we've had the BAPM this year, we've designed this preterm delivery checklist as part of the optimization care pathway, with a view that we have a meeting, a joint meeting with the obstetrician before delivery. So the midwife goes through this checklist before delivery and ensures that there's discussions about delayed cord clamping, and parents are informed about the benefits. And at delivery, again, there's a reminder to go through this list and make sure it's been done, and post-delivery for other things to ensure that placenta and the cord bloods are all taken. And the aim is to incorporate this into Badger checklist, so we know that it can be documented in the Badger at the maternity side. And that will help us to do this for all babies once we're getting much better with the preterm babies under 34 weeks. As a part of this, we also produced a new parent information leaflet, which is now being incorporated into BadgerNet, just waiting to get on in the BadgerNet. It's been ratified internally, so parents, mothers could actually access this as part of their booking, and it'll be available in their handheld records, so they can actually refer to it and remind everybody at the checklist in preterm deliveries before the delivery. And one of the other ways to try and encourage everyone to remind and keep delayed cord clamping at the forefront is to do loads of simulations. I think simulation is what really helped us to get this started in the first place, and having regular newsletters as part of SIM team helped us to try and tease up little things and teach the team on a monthly basis small snippets of information. Our team got shortlisted for the BAPM Improving Perinatal Care Award in 2020 for the work that the team did on implementing deferred cord clamping. And I'd like to say thank you for our charity who helped us to get the equipment in the first place. While it's not essential to use any special platform, I think in our setup, it's given the confidence for people to initiate this, and now we're trying to learn to do without having to resort to it in all circumstances. So thank you.
Anela, thank you so much again for another really thought-provoking presentation. And just things that I picked up on that I really enjoyed is things like the layout in theatre and in delivery suite. I think that's really useful for clinicians, and the parents and staff feedback is fantastic, along with things like the leaflet for the parents and checklist for staff for the 34-weekers. Has anybody got any questions they'd like to ask? They can raise their hand or put it in the chat box. Let me see, I'm just trying to work out whose hand that is.
I think
Helen's.
Yeah, thanks, Anila. Really nice. I've seen that before, and it's still very inspiring. It's a slightly provocative question, but you mentioned that using the Life Start gave people confidence, and I wondered if it also maybe made them a little bit more likely to instigate a bit of resuscitation.
I think yes, it's probably both ways. I think in the beginning, people were not wanting to change from cord milking. If we hadn't done any form of deferred cord clamping, I think people may have been willing to try and do something different from immediate cord clamping. We started off at a place where we were doing cord milking, and cord milking is still, useful. We just heard from Heike. It's not been shown to be the top option to do, but it is the next best option at this point of time, given the evidence. So getting people to change from that to something different, everyone was so nervous, and they said to me, oh, you can't, how, if baby needs any resuscitation, how are we going to do? And this is for all preterm. So we're talking about 23, 24 weeks. And in the beginning, so much was was on the, I think, focus on what can I have as a kit to help me. And yes, that made people use it a bit more. And these videos were taken on one afternoon when the unit was really busy, and it was like 7th or 8th shot. And I got tired of correcting people and directing it. So I let them flow. And you can see even there, people were not so good about infection control because they were so enthusiastic at simulation. The scrub nurse is touching the hands of the scrub doctor and so on. So I think it has been a challenge. It's not been easy. And I don't advocate everyone to use the equipment, but I think what I would say is do simulations in your unit, find out what your team needs, and then start somewhere and improve it. Because you would only have to start somewhere and then you can work along to improve it.
Yeah, okay, thanks. The wise words. Yeah, thank you.
Sorry, I was on mute, sorry. Freya said you mentioned the importance of theatre temperature. What temperature do you advise?
Oh, it's a big debate, isn't it? Well, you normally would need at least 23 to 24 degrees, but I can say from my unit that is not possible because of surgical site infections, that they would not want to have higher temperatures. So I think the idea is you work with the obstetrician, find out what's kind of suitable upper limit, and then if the environmental temperature is something that you can't actually, bring it higher than what you would you'd be allowed to, use things that you can keep the baby warm. Basically having an attention to detail, having a focus on temperature. Then you could use we have a towel warmer, so we use pre-warm towels to top up on top, and covering the baby fully helps as well. The platform that we use has got a heating base, but that doesn't really work well. So we don't actually bother with it, but we use transformer in addition if we needed to, if a baby has a prolonged stabilization.
Thank you. And we've got one more question, and that's Heike.
Yes, hello. I just want to thank Vinula for the nice presentation, and I want to emphasize there's now, regarding to twins and triplets, there's now published a study which showed that optimal cord clamping is also manageable in twins and triplets, so that's not a contraindication. And the same for short cord. You just, it's still feasible and possible. Of course, you can't use a trolley then. And that was actually the case in the primary pilot study when they used the trolley for the randomized control trials. That 25% of babies in the trolley could not be used because the cord is not long enough. So just to re-emphasize that the twins and triplets deserve their blood as well. That's all.
Thank you. Yes.
Thank you very much. I think that's all the questions. Back to you, Helen.
Okay, thank you. So next, it's very nice that we have Penny Bliss, who's a practice development interim compliance and safety midwife at Maidstone and Tunbridge Wells, and she's going to share results of local implementation of optimal cord management in clinical practice at her workplace.
Hi Penny, you're on mute.
Sorry, computer, it's being very slow. Hopefully you can hear me now.
We can hear you, yes.
Fabulous, and I'm hoping you can see my screen as well. So, I'm Penny Bliss. I am presenting on behalf of Sarah Gregson, who was our consultant midwife at the time that we implemented optimal cord management into clinical practice. I'm going to briefly go over this from a very briefly recap research and physiology, the guidelines, and then the barriers to implementation and how we overcame them and implemented that. It will be slightly different because from our trust perspective, it was very much led by our consultant midwife, with some of the barriers coming from our neonatology colleagues, rather than the neonatologists leading on it. So it has some it's a bit of a different perspective. So what we start off with, we looked at current practice. What are we doing at the moment? So when we implemented this, it was in 2014. And we were literally, baby was born, clamp and cut the cord. There was no delayed cord clamping, cord milking, anything like that. So that was our starting point. So anything was going to be better than where we were. So then we went on to look briefly at like the benefits of delayed cord clamping. So obviously you have reduced anemia. Particularly for preterm infants, you have a reduced need for blood transfusion and a reduced rate of intraventricular hemorrhage. Are there any limitations? Well, I will cover this briefly, but one of the limitations of it is potentially from 2019 there was a study published and it recommended that you don't do any cord milking in babies that are under 34 weeks of gestation because it increased the rate of intraventricular hemorrhage. So this is something that we actually took on, and we don't do any cord milking for babies that are under 34 weeks of gestation. But we do delayed cord clamping or cord milking for babies over 34 weeks. But I think really what this initially came down to is what are we trying to achieve when a baby is born? You have a baby that's born and you want them to be well. We have to look at this from a physiological perspective. If you've got a baby that's born and it's maybe not making much respiratory effort, but it's got some relatively good colour and some good tone, then actually you have the time to be able to afford to wait a minute. If your cord's pulsating, your placenta's clearly been functioning up to that point for that baby to come out in fairly okay condition. Either that, and they're still in neonatal fetal circulations, they're in transitions into neonatal circulation, and therefore, you know, completely acceptable to wait a minute in order to delay that cord clamping and clamp and cut the cord. Obviously, if they're screaming, great, wonderful, they're making respiratory effort, no rush. The only time we'd say that it wasn't particularly appropriate to wait, and this is what we train on, is if you've got a baby that's white and floppy, because we know that up to that point there's probably been some placental insufficiency for a baby to come out in a condition that is that point. It's likely, we can't prove it, but it's likely. And therefore, at that point we would recommend milking if possible, or just clamping and cutting of the cord. So then we look at our guidance. Now, we actually had over 90% of our staff had received training before this guideline was introduced. As I said, this guideline was introduced in 2014. It was a project that we actually commenced in 2012, but in order to get 90% of our workforce trained, we wait those 2 years. Now, with all our guidelines, this guideline had a very rigorous process. We start by the guideline being written. We thought it fitted, here we're focusing on preterm infants. So it's in our care and labour guideline for term infants, and preterm, our guidance is slightly different. So this guideline was written, it goes to key stakeholders. So this was actually discussed with our paediatric colleagues, neonatal colleagues, delivery student ward managers, coordinators, etc., etc. It actually goes out to comment, all of our guidance goes out to comment to all of our midwives in order for them to comment. And then it goes through our guideline group and our maternity risk review group. So as you can see, there's quite a stringent process in order to get anything passed in the unit. So this is a lot of time and effort went into making sure that this guidance was appropriate, on point, and as good as possible before it gets published. But it also enables all midwives to have sight of the guideline before it's published, so they're aware of changes that are coming up in practice. Because we all know that, you know, one of the biggest things is changing practice. So, The couple of the barriers which I know my presenters before me covered is the need to maintain temperature and thermoregulation when you're doing optimal cord clamping. Now, as they've covered, we in theatre don't have our neonatologist scrub. We have our midwife scrub in theatre, and they either have the plastic bags for very premature babies, or we have a sterile towel in order to cover and to dry the babies as well. And then the midwife or another member of the theatre type team will keep an eye on the clock. They'll tell you when your 60 seconds is up. So we kind of had that as a barrier, along with our multidisciplinary communication. And one of the biggest barriers we had was about paediatric and neonatal anxieties about the increasing rates of polycythemia, which would then require exchange parent transfusions because of jaundice in the neonatal period. I think we had to do a lot of educating around the fact that we're not giving babies extra blood, we're giving them back their own blood that they should have. So we actually had to then do some audits, and our audits showed that a number of our babies that were at risk didn't get delayed cord clamping, particularly if they were born by cesarean section. But more relevant to this is that about 4 out of 10 of the preterm babies that did require an exchange transfusion had delayed cord clamping out of our guidelines. Our guidelines specifically focus on delayed cord clamping of over 60 seconds, but under 2 minutes. So we have a very strict guidance on that for preterm babies. Again, for term babies, there's no limit, but for preterm babies, it's between 1 and 2 minutes. So that those that did, but actually, even though that we had some premature preterm babies that required exchange transfusions, there was still no increase of the overall rate of babies requiring exchange transfusions because of jaundice. So once we carried out that audit, it was a very good tool that we could then share with our colleagues. We also identified poor compliance with the guideline. This was our first audit in 2014. So that actually preterm babies just, as I've said, they weren't getting delayed cord clamping. So, once we find these, it's all very well doing audits, but then you have to go back and do a lot more staff training around this. So upon further investigation of this, we revealed that, for start, our staff had a poor understanding of management of the third stage and management of delayed cord clamping, depending on whether it was physiological or active management of the third stage. Probably what was one of the findings is because they actually just weren't great at documenting this. So we had to go back and completely rethink all of the work that we'd already put in. So we've done a lot of work on getting people ready for delayed cord clamping, getting them really passionate about it, getting them our neonatal colleagues on site to work with us on this. And then we actually found a whole other issue about management of the third stage of labour. And then on our prompt training days that we do, we had already implemented delayed cord clamping as a hot topic because we were introducing it. So then we had to do a whole lot of work on the third stage of labour and how you manage that cord clamping, and that you need to write it down, and we changed our notes in order to document this effectively. We did a second audit in 2018, which showed improvement in all areas, but there was still 18% of our babies were not getting delayed cord clamping who should have had delayed cord clamping. So, that's really important that we'd made strides and we'd done a lot of work, and we'd really got people on side and started to embed it in practice. But even in 2018, this still wasn't enough. So, number one barrier was staff training and implementation of change of practice. So I've talked a lot about teaching and training that we did, but this was our biggest barrier to implementation. So not only did we focus on staff teaching, we developed infographics that showed the benefits of delayed cord clamping on them, as well as doing monthly infographics for the amount of babies that did have delayed cord clamping and didn't, so that we could track improvements easily as well. We did loads of posters. We've done, as I say, basically monthly audits. We did at the time. We don't do them anymore. It's pretty well embedded, but yeah. And then we had a launch day where we did trolley dashes around the unit. So we do trolley dashes fairly regularly, and we did trolley dashes around the unit to inform everyone what's happening. And we had balloons and cake, and we had, I find if you feed midwives cake, they're much more likely to do things the way you want them to do them. So I don't know if that crosses all professions, I'm sure it probably does, but yeah, it's always very successful. And so we launched this again to really try and get staff buy-in. We also looked at how we could address the barriers. So we did a film for a birthing person and their birthing partners to be able to implement, to be able to ask for delayed cord clamping, to empower them with that knowledge to ask for it. This was viewed by over 30,000. We've had over 30,000 views on this video, and it's called Baby Friendly Cesarean. We had a sterile towel in order to cover babies in theatres, because the majority of our very preterm births were via cesarean section. We implemented teaching aids, not only for midwives and for obstetricians, but also for our theatre team, because of course the majority of these were happening in theatre. So we had to implement that. And then not only did we have to do that, but we had to then work on communication between our staff groups. You have conflicting interests. You have the obstetrician who's just interested in delivering the baby, stopping bleeding, making sure the birthing person is well at the end of it. You have the paediatrician, neonatologist, who is desperate to get hands on the baby to commence any interventions that are needed. And then you've got a midwife who anxiously wants to get the baby to the neonatologist. And then you've got a theatre team who are potentially under strain and pressure because they'll have misses and groups going forward. So it was working on that and the communication between them in order to alleviate some of those anxieties and in order to make them communicate effectively with one another. But particularly involving our theatre team in this, as more often than not, they will now count out our minute for delayed cord clamping in theatre, which is really helpful. And then, as I suggested, once we got our audit results in, we then focused on training and findings surrounding these. So yeah, now we can look at our current statistics. So this is our last year, April 2020 to 21. We had 5,627 live births. 89% of them had delayed cord clamping. Brilliant. What we can see is that 318 of these births were preterm births. We're a level 2 unit, so only very preterm we try and get out to level 3. 68% had delayed cord clamping. The earliest gestation that had delayed cord clamping was 24 weeks and 5 days. Obviously, sometimes we don't get the chance to transfer babies out. And 26% had the cord milked. Now, of course, for us, that's over 34 weeks because we've implemented the not milking below 34 weeks in the unit, which means that only 6% of preterm births had neither delayed cord clamping nor the cord milked. We say only 6%, but that's great. However, what we've now got to work on in reducing that as far as possible. There are probably always going to be instances beyond our control if you've got birthing people who are unwell, or babies that are born extremely compromised, where you may not be able to do that. But we need to, every baby counts, and we need to make every effort possible to not let that, with every baby, to every possibility to not to have delayed cord clamping or cord milking. I will post the link, it's just some references, because this is what I used, and you've got the 2019 study there that we used about cord milking increasing intraventricular hemorrhage. And I will post the URL to the YouTube video in the chat, so it's there if you would like it. If anyone's got any questions.
Penny, thank you so much. That was fantastic, and congratulations on your trust statistics. Very, very impressive, and I'm sure everyone is quite proud of what you've achieved. And again, I really like the fact that you discussed the barriers that your trust have faced and the importance of the communication between the multidisciplinary team and how important it is that maternity and the neonatal team all work together. And I think it was really good to have a sort of midwifery maternity perspective, so thank you very much. Has anybody got any questions they'd like to ask? They can put it in the chat or raise their hand. Helen?
Yeah, I was just going to say, well done, Penny. They are really impressive results. I'd like to think we can achieve the same here at Medway. I mean, I think your main kind of focus there was about the communication, and I think, you know, it just shows what an important part of the work that is. Just noticing that your figures are amazing for your overall births. Do you think there's a bit of work to do with your neonatal colleagues to get that data? Although it's a really small number that would flag up on NNAP. I think when I was looking at for 2020, there were only 8 eligible across the trust, but data in for 2 of them. So you could probably very easily get up to 100% before the rest of us, I think.
Definitely. We discovered that, well, actually, looking into this, we discovered that, again, our Euroking doesn't talk to Badger.
Yeah.
None of that is getting transferred across.
Yeah, it's a real shame, isn't it?
Yeah, so it's definitely something we need to flag to make people aware.
Thank you. There's a slight change to our agenda. Chim, unfortunately, has been delayed in her clinic. She's very busy at the moment, but we have got Claire Redfearn, who has very kindly agreed to step in at the last minute. So thank you very much, Claire, for doing this. It's literally been within 5 minutes, so we're very grateful. Are you about, Claire?
I am, yes.
Yeah, thank you. Over to you.
Hi there. So I'm Claire Redfearn. I'm a consultant obstetrician and labour ward lead at QEQM East Kent Hospitals. Can I just say thank you so much for all of the presentations. They've provoked a lot of discussion here. We've kind of set up 2 little workshops, one at William Harvey and one at QEQM, to see how we can continue to improve our data as well. So I've been asked to talk about from the obstetric point of view, and I think the data and the physiological aspect is really important. My colleagues talk to me and the theatre team come to me and say, I see people milking the cord, I see people doing delayed cord clamping, which is the better way? So thank you. I think there's work to do to look at the clarity about the increased risk of interventricular hemorrhage, or whether that's not the case. But overall, I can see the definite benefits of delayed cord clamping. I think it's getting that education out there to all of our obstetric colleagues about delayed cord clamping. And it's really important the use of the sims to set up these scenarios. Often it is lovely when it's a controlled setting and you're going into theatre and you've got the time, but I know from our point of view, being a level 1 unit, we do sometimes get caught ad hoc with these very quick deliveries of very premature babies, and it's being slick to be able to make sure that these babies are achieving that delayed cord clamping. And also the estates, from an obstetrician's point of view, whether it's vaginal delivery or a cesarean section, it's looking at about how we can implement that delayed cord clamping, depending on whatever setting we're delivering the baby. And I think the highlight is the multi-professional working with your team, working with your neonates or your paediatricians to come and help enable that. I'm not afraid of getting too close, as we saw from that YouTube video. Then there's a lot of people in one room, we're just all working together for that baby. I think the obstetricians can do a lot. We've been talking about team briefs before cesarean section to help raise awareness with the theatre staff, anaesthetists, and the midwives and obstetricians doing the cesarean cesarean section to improve delayed cord clamping. And it's also nice to see the birthday cuddle. We often have the mums on the postnatal ward and they're really distressed because they don't know what's going on with baby in NICU or SCBU, and so it's really nice if they do have that opportunity with them. So that's really nice as an obstetric point of view. It's really interesting to hear about data and how it's collated and how we're all digital with EuroKing and Babnet and how we ensure that our unit's data is accurate. So that's another area that we'll take away to have a look at how we ensure that our data is really accurate there. The preterm checklist, I think, was an amazing example of how we can improve the perinatal optimization, and definitely as obstetricians working in a busy unit, it would be nice to have a succinct checklist or pro forma to ensure that these preterm babies are getting everything that they need. And it was also nice to hear about the BAPM's guidance about special circumstances. So that's definitely something from an obstetric point of view, is when you get variation on when's delayed cord clamping okay, when they're not, such as the monochorionic twins. So thank you very much. Hopefully that's a few obstetric aspects with regard to delayed cord clamping. Thank you very much. I don't know if anybody's got any obstetric questions regarding delayed cord clamping, but happy to help if needed.
Vanella's got her hand up.
Hi Claire, lovely to hear from an obstetrician. I just have a little question really, because one of the things it was interesting for me to learn when there was twin deliveries, our obstetrician said, particularly in preterm gestation, so like under 28 weeks, you know, often there's one comes out and there's a delay because we're deferring the cord clamping before the second one comes out. And apparently the second one can actually shot up to the fundus, and if they let their hands off, and therefore if they have to come and clamp, then they're worried that the other baby will just fly up to the fundus and it'll be hard to get the baby back in, and therefore they've kind of hinted to us that we may have to clamp the cord like the scrub neonatal doctor. It's the first time I heard in our team, which we're trying to explore. Is this something that from your view you've come across before?
So no, with twin deliveries, obviously once twin one is delivered, if somebody is there to maintain baby and to assess and to allow that delayed cord clamping, what the obstetrician will then be wanting to do is to assess what presentation that second twin is coming down into. At very extreme preterm gestations, they can get into whatever position that they want, but obviously it can be quite difficult, especially if the waters go, because you need to either have a head or 2 feet to be able to deliver easily. Going up into the fundus and being unable to get them, normally what happens is the uterus will then start to contract and you will be presented with some part of the second twin that would be able to be delivered. So I think the main reason why I get a bit panicky about cutting and clamping the cord is if there is a maternal reason. So often these women may be having significant bleeding from the uterine incision where we've done the cesarean section, and therefore we need to expedite delivery to help that uterus contract and to reduce the blood loss for the mother.
Thank you.
Oh, is that a question from Helen?
Sorry, thanks Claire, that was great for you to step in at the last minute. So I was wondering about your, maybe I missed it, do you use cord milking?
So there's variation. The majority are delayed cord clamping where we don't touch the cord, we keep the baby mainly on the mother's legs. So often there's the Lion King moment where you want to show the mother their baby, but then we often get the baby back down onto the mother's legs to reduce that gravitational shift of the placental transfusion. And then we often use the timer on the resuscitator for a good minute before cutting and clamping the cord. So yes, the milking, obviously we have rotation of doctors within obstetrics from different units, and sometimes they will milk the cord, maybe feeling that this may quicken the time that they could then clamp the cord, but also give the baby the benefits of that placental transfusion. And I think because theatre staff see a variation in us obstetricians and what we're doing with delayed cord clamping, then they question but I think it's getting that education out about the benefits. And I think this is where we need the clarity about the risks. One of my colleagues asked me the questions about, can we do milking in like a 23-weeker? Because obviously with compression and milking, there's a thought that potentially there's a high volume going in quickly into the umbilical cord and fetal circulation. So has that got any potential risks? So that's why I did ask that question earlier, because that is something that a lot of my obstetricians come to me to ask, is milking an acceptable equivalent or not?
Okay, thanks.
Sorry, I know there's been comments put in the chat box.
Oh, sorry, I haven't got my chat box up at the moment.
I think they're just, so one's asking Penny about sharing the tool, and we have a great ODP maternity lead. She used to be an MSW and they developed a training tool. So I think that's just general people's comments and things. Thank you very much again, Claire. Much appreciated. Thrown into the deep end there.
That's all right, don't you worry. Glad to
really
help.
Appreciate it. Thank you very much. Back over to you, Helen.
Okay, thank you. So we've, I think we've pretty much kept to time, and I've really enjoyed today. It's been really nice hearing different perspectives, not just the neonatal ones, which are great, but I think just realizing that we are a greater team here and all on board with improving outcomes. So I think it's over to Ursula to maybe just summarize and say what the next steps forward are for us as a network.
Hi, everyone. Next slide, please. Bav. So what can we do to support you, or how are we going to support you going forward? I think as a region, we have got a really well placed, we're in a really good place to actually make a huge difference. We've got enthusiasm. We've just heard, we've heard Heike, we've heard Vanilla, we've heard Penny, we've heard Claire. We've got really enthusiastic people across all three counties, which I think can and will make a huge difference to what we're going to do. It's one of our primary projects that we're going to do this year, and we're also working really closely with the ODN and the ODN team to do that. So just a couple of kind of little ideas for next steps for those of you who maybe are starting out in this project. So next slide, Bav. So really do you think you should choose your team? Really, we should really have representation. Obviously, maternity obstetric, the neonatal unit, theatre. I think it's really important to have theatre, and QI team. I think to have somebody from maybe your QI team, because remember, this is part of the MatNeo program, and we're hoping that your QI will actually, we know we've been doing it for 3 years. The last year we haven't been doing as much kind of methodology, competence and capability training, and hopefully your trust who have a QI team will be able to help you with that. I think I've seen Louise is here from Royal Surrey, I think, and Louise has obviously been somebody who was really involved from a QI perspective in the past, and it does make a huge difference. I think we need to obtain a baseline data, and actually just about 15 minutes before this webinar started, Jen from the ODN actually put in an email to say that we believe Jackie, who's the analyst within the ODN, would be able to give baseline data per maternity unit. So that can really help us to kind of look at what baseline have we got, and where are we going to, where do we feel that we can achieve in the next year, and what can we do? Possibly do a process mapping exercise to identify areas that need improvement. So we've seen in the chat today that people have said, what is it, the one area that you think could have made a difference when you're looking back on it? And they're the kind of things which would probably be different in each of the units across the 3 counties, and that's something that probably we can kind of help you with. You need to then decide, following that mapping exercise, what is the change idea? What is the one thing that you really do need, you think that you should work on? So if you haven't got a guideline in place, maybe we can talk to Maidstone Tunbridge Wells about their guideline, or other areas that have got guidelines to look at what they've done. I really like the idea of that theatre person in Maidstone Tunbridge Wells who's done something for theatre, because I'm not sure there would be as many theatre staff who would have an MSW as part of that team that probably can see things from a very maternity perspective. We can do an improvement plan. So Nanette and I
we are here to help you and support you, and Helen as well from a clinical perspective. We can help you complete an improvement plan. We can do one of those plush plans that you can actually then submit to your head of midwifery or to whomever, your QI team, as looking at exactly what it is that you're going to do. And Helen very earlier on talked about how Precept worked. And we think it worked because there was a kind of a champion in each area, in each particular site. I know we don't actually have funding like we did for Precept, but I think by having a named individual who maybe has a passion for this, that could really make a difference. And we're hoping as time goes on that we can maybe do site visits. So Nanette, Helen and I could do site visits to see where you are, you know, little areas where we can maybe be a little bit of a kind of a critical friend, if that's the word to use, to look at from an outsider perspective, what is it that, you know, we think that could make a difference. So they're the kind of little starting points, and I think what we probably would do is as the next few weeks come on, we'll contact each of you, and Nanette has started to do that already, to actually find out who is the QI lead and the MatNeo lead within your units. So once we get that, we'll probably get a group together and look at what we can do. We are going to be doing different events as the year goes on. We'll probably do a large event, maybe October time, or, you know, the autumn or spring, and which we'll kind of, then we could maybe bring results of what we've been doing in this project then. Next slide, please. I think, yeah, actually, yeah. Before I say about the Curiosity Call, just to let you know that the 21st of July is our next event. We've also been encouraged this year to work with Oxford and Wessex, because as you know, our ODN links across, and also the South East of England regionally, the Regional Chief Midwife links across Oxford and Wessex as well, and also the new obstetric lead will also link across Oxford and Wessex. So we're working with them to do a session primarily on QI. So those of you who are going to have new teams, we're going to do a session on QI methodologies, and we probably will bring in parts of this particular, like the pre-optimization work stream, as part of the kind of examples when we're talking about different aspects of QI. So the Curiosity Calls, I don't know whether those of you who maybe have understood that, perhaps Bob, we can put a link in the chat. They're a really good idea into looking at, it's just where you're getting a random person across Kent, Surrey and Sussex who works in QI, works in MatNeo, and just have a chat with them. This month, on the 1st, you get on the 1st of the month, I got Dawn Kerslake this month who works in CCAM. So I had a chat with her for about 20 minutes, and it was great because she was telling me about the preterm guidelines that actually they're putting in across CCAM, and just different aspects of maternity within CCAM that they actually are concerned about, etc. And then I offered to do some QI with her team, so that we can kind of all be thinking from the same side. So I think they're a really nice way to kind of get to talk to each other in a non-hierarchical, all interested in QI, and just those of us who love the work within MatNeo. So I think that's about it. I'd just like to finally thank really the team for putting this together. Thank you to all our presenters. That was amazing. Thank you to Bav, Karen, Sharon, and Helen, and everybody who's kind of worked on this. I'd like to particularly thank Nanette, because this, you know, she's been working with us for the last couple of years, twice a week, and now she's with us full time. This is the very first one she's done from scratch. So I think we need to give her all a little bit of clap, 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 and say thank you very much, and thank you, Nanette. And that's it. So thank you very much. And we will see you hopefully in July. I'm being very much in touch with you until then.